Hi, so we wanted to show you briefly how to do an ABCDE assessment on a trauma patient, or a primary assessment on a trauma patient. And the idea here is to identify life threats. So A is for airway, and I'm just looking at my patient Gary here. I say, hi Gary, how are you?
I'm okay.
Okay, what do we know about his airway? It's open, it's clear, he's talking, there's no extra noises coming from the airway, and he's alert enough to maintain that airway. So airway in this patient is fine. Now we move on to B, which is breathing. And if this were my actual patient, I would have my friends here cutting his clothes off for me. I do want to be careful as I expose him to not cool him off. And now I'm just doing inspection first of his breathing. And when I'm inspecting, I'm looking for symmetrical chest rise. And I'm looking to see that A, he is breathing, and B, that the rate is approximately normal. So somewhere in the 10 to 20 range. Anything too fast or too slow could indicate a life threat. And when you're doing a primary survey on a trauma patient, you stop if there's a life threat and you fix that problem before you move on. So I've inspected, I would want to palpate. So that symmetrical expansion, take a big deep breath. And I feel both of my hands rising and falling. Then I would just palpate for tenderness across his thorax. If like one of my hands dropped in when he inhaled, it could indicate like a rib fracture and an unstable chest wall motion, which again can be a life threat. So now we get to circulation, and this is something that we can kind of assess almost right away. He's pink, he's warm. I feel a 2+ pulse right here. And his cap refill is less than 3 seconds. So I'm feeling pretty confident about his circulation already. Circulation also, in addition to these things that I can inspect and I can palpate pulses, you can also look for gross hemorrhage. So if your patient's bleeding out somewhere that's obvious to you, you apply pressure and you don't let go of that pressure until you have a definitive way to stop it like an OR. The other thing is, say that my patient has weak and thready pulses, he's pale and diaphoretic, but I don't have an obvious source of hemorrhage. That's when I'm thinking he's got internals. And the places, Gary, that people bleed, especially in blunt trauma, is chest, abdomen, and pelvis. That's where you can bleed to death internally. So now, as part of my C, I might move into here, and I'm inspecting, I'm palpating. I inspect for any kind of signs of trauma, like bruising or abrasions, and I palpate for any kind of rigidity, which might mean there's extra fluid underneath my fingers, like bleeding. I would also palpate to make sure that the pelvis is stable. And I don't want to like bounce on that, because if it is unstable, I can make bleeding worse. But I just want to feel to make sure that my hands don't wobble under his pelvis, because that would indicate a bad fracture and a high potential for bleeding. So that's ABC. D is major neurologic disability. So I want to know that he can move all 4 extremities. And most importantly, I want to make sure that this patient is alert enough to talk to me. If he's really hard to arouse, we might think that he might need intubated to protect his airway. So A, B, C, D, E. E is very important. It's for environment and exposure. Environment being, is this room warm enough to keep this patient who's been involved in a serious trauma warm? And exposure, is there anything that I can't see right now that could potentially kill this guy? And the truth is, we would expose all of him, always being careful to expose and then cover so we don't make him too cold. And then we've got to turn the patient, because I can't see his whole other half. To turn a trauma patient, you always use C-spine precautions, and you have to have at least 3 people. So ladies, we're going to turn to his left on my count. We're going to turn on 3. Are you ready? 1, 2, and 3 to the left. And the team does all of the work for the patient. And at this point, my trauma team would have all of his clothing removed. We would palpate his spine for any step off, meaning bad fractures or tenderness. And we would be looking for other signs of trauma like bruising, abrasions, punctures, anything that we couldn't see on that initial inspection. All right, ladies, we're ready to move back. 1, 2, 3. And that is ABCDE on a trauma patient. And we just also included in that how to trim the patient.